Yeah. Okay, so I think we get started. So on behalf of Nico Seiberlich, who cannot join today, she's traveling today, but she sends her best regards to everybody. She will be back on October 2nd. I'm welcoming all of you to a very special edition of our CMR Journal Club with two very interesting papers around a technology that has taken over in terms of clinical accuracy the previous big elephant in the room, which is nuclear, to assess for myocardial ischemia or inducible perfusion deficits. So the two papers we have today are by Raymond Kwong's group from Boston and by Marco Goethe's group from Amsterdam, and presenting will be Benedikt Bernhard, now in Germany, but having stayed for 1.5 years with Ray, and by Sonia, which I'll introduce a bit later. So without further ado, you know the rules. It's very informal. It's just 10-12 minutes of presentation and then time for some questions, just to walk through the PDF. So Benedikt, take it from here and walk us through your paper, Association of Adverse Clinical Outcomes with Peri-Infarct Ischemia Detected by Stress, CMR, published in JACC earlier this year.
Yes, thank you for the invitation and for the kind introduction. As you already said, the paper I'm presenting today was just recently published in JACC, and it focuses on peri-infarct ischemia detected by stress cardiac magnetic resonance imaging. And before I focus on the study, I'd like to take a brief moment to provide some background information on peri-infarct ischemia to help you understand the rationale behind this project. Peri-infarct ischemia is defined as myocardial scar surrounded by ischemic myocardium and arises from acute myocardial infarction. It may result from several factors that are associated to myocardial infarction, such as residual stenosis after revascularization, incomplete or late revascularization, microvascular disease, or chronic hypoperfusion of myocardium supplied by coronary collaterals. And based on limited evidence from small observational studies, mostly from nuclear imaging, peri-infarct ischemia might trigger ventricular arrhythmia, negatively impact adverse remodeling, and might also increase the risk for reinfarction. As I said, it was so far mostly described in nuclear imaging studies. However, CMR has the ability to look at both the extent and the presence of ischemia and myocardial scar by LGE at high resolution, and even to co-register these two techniques next to each other. I'd now like to jump to figure 2 of the paper. We'll also come to figure 1, but I think it's easier if I start with figure 2. Yes, here you can see 3 patients with still images of LGE and stress perfusion sequences. And in patient 1, you can clearly see that there's endocardial, maybe even here transmural LGE in the inferior AHA segment and then also in the inferolateral segment. And if you compare this sequence at the same height, you can see that you don't only have ischemia, a stress perfusion defect in these 2 segments, you also have ischemia extending in the anterolateral and also in the inferoseptal segment. Similarly, in patient 2, you can see transmural myocardial infarction in the RCR territory, involving 2 segments with transmural extent and 1 segment here with an subendocardial defect. And if you compare this with the stress perfusion sequence, you again see that the ischemia is extending in the anterolateral and anteroseptal segment. And this is what we would call peri-infarct ischemia in this context. Peri-infarct ischemia must not necessarily occur in the same slice of LGE and stress perfusion. It can also be present at another short axis level, as demonstrated here in patient number 3. In the LGE slice of the basal myocardium, you don't see any defect. However, if you scroll a bit further to the midventricular area, you again see a large myocardial infarction in the anteroseptal, anterolateral regions. And if you compare this with the stress perfusion defects, you'll see that there is also stress perfusion in the basal slice, which would also meet the criteria of peri-infarct ischemia in this context. This brings us to the hypothesis of our study. That was that peri-infarct ischemia assessed by stress perfusion CMR is a strong marker of cardiovascular outcomes, incremental to clinical risk markers, and also incremental to the individual extent and presence of LGE and ischemia. To test this hypothesis, now I like to go back to figure 1. We combined patients of 2 cohorts. On the one hand, we included 2,349 patients from the original SPINS cohort. These were patients with stable chest pain syndromes referred for stress perfusion CMR across 13 US centers. And we expanded this cohort with 1,900 patients from the Brigham and Women's Hospital that met the same inclusion and exclusion criteria as the initial SPINS cohort. We excluded patients with non-diagnostic stress scan, with any other significant cardiovascular disease that might also go along with a large extent of LGE. We also excluded patients that were lost to follow-up, which were only 53 patients. So finally, we included 3,915 patients, and in all these patients, we assessed the extent of ischemia by the number of AHA segments, the extent of LGE by the number of AHA segments, and we determined the presence and the extent of peri-infarct ischemia as demonstrated in the examples before. The primary endpoint was a composite endpoint of acute MI and cardiovascular death. And we also looked into a secondary endpoint that included the components of the primary endpoint, acute MI and cardiovascular death, but also heart failure hospitalization, hospitalization for unstable angina symptoms, and also coronary artery bypass graft operation occurring more than 6 months after the index CMR. In table 1 depicted here on the left, you can see that we included a typical cohort of patients with suspected coronary artery disease. Their mean age was 61 years. About half of the patients were male. Cardiovascular risk factors were frequently prevalent, with about 2/3 of patients suffering from arterial hypertension. About 20% of patients had an established history of coronary artery disease by either previous PCI or previous CABG. And peri-infarct ischemia, as demonstrated here in these 2 different columns, was present in 382 patients, which was about 10% of the cohort. And as you can see here, this is the cohort of patients with peri-infarct ischemia. Patients with peri-infarct ischemia had a lower LV ejection fraction. Of course, they had higher presence and prevalence of higher extent of scar and ischemia, as this was included in the definition for peri-infarct ischemia. At the median follow-up, we followed all these patients for a median time of 5.2 years. And after this median point had occurred in 406 patients, which were about 10% of the cohort, while the secondary endpoint occurred in 745, about 20% of the cohort. And as presented in table 2, and I'd like to scroll down a bit further, several clinical and demographic characteristics were associated with both endpoints. There are many things that are not very surprising. For example, a higher age was associated with both endpoints. However, I'd like to bring your attention to these 2 lines where you see the univariate Cox regression analysis results for peri-infarct ischemia and also peri-infarct ischemia extent by the number of involved AHA segments. And here you can see that peri-infarct ischemia was associated to the primary endpoint of acute MI and death with a hazard ratio of 4.6, and to the secondary endpoint with a hazard ratio of 4.3. Consistently, also the extent of peri-infarct ischemia was associated with both endpoints with a hazard ratio of about 1.4. These findings are also reflected in the survival curves, in the hazard curves, sorry. Here on the left side, you see the hazard curve for the primary endpoint, on the right side for the secondary endpoint. And patients with peri-infarct ischemia are represented by this purple line here. And you can see that they had worse outcomes compared to all other groups. Of note, outcome of patients with peri-infarct ischemia was also significantly worse compared to patients represented by this turquoise line. And these were patients that had ischemia and LGE, but not close to each other, that they would meet the definition of peri-infarct ischemia. They had ischemia and remote infarct that were not in a close correlation to each other. And these patients had a better prognosis compared to the patients with peri-infarct ischemia. These findings are also reflected by the annualized event rates that are depicted here in this central illustration, again on the left side for the primary endpoint, on the right side for the secondary endpoint. And here you can see that patients with peri-infarct ischemia, represented by the bar on the right, had an annualized event rate for the primary endpoint of 6.5%. These are stacked graphs. Red represents the number of CV deaths, and blue represents the number of acute MI, while we can also see that for the secondary endpoint, we have stacks for late CABG, unstable angina, and heart failure hospitalization. For the secondary endpoint, patients with peri-infarct ischemia had an annualized event rate of 10.3%. You might also have realized, as a little side note, maybe the excellent negative predictive value of a normal CMR. As you can see here, patients without any ischemia or infarct had an excellent prognosis with an event rate of only 0.9%. Now, one might argue that patients with peri-infarct ischemia were simply sicker, had worse LV function, and had therefore a worse outcome compared to the other groups. That's why we also went for multivariable Cox regression analysis, and you can see the results for both endpoints here in this table. And we took all the variables presented in table 1, put them into a stepwise forward variable selection process, and finally got these 8 variables out that were the strongest, that represent the strongest combination of variables, the strongest model to predict the primary and secondary endpoint. And in addition to peri-infarct ischemia, the other things are not very surprising. We have age as a significant predictor, LV ejection fraction, the presence of diabetes, smoking, prior CABG, also the ischemia extent measured by the number of involved AHA segments, and also the LGE extent. And what is quite interesting is that in this table, the variables in the model are ranked by their reduction in IKK information criterion, which is a metric for the predictive power of each variable. And as you can see here, among all these variables, the presence of peri-infarct ischemia was the strongest independent predictor for both the primary and the secondary endpoint, corresponding to a hazard ratio, to an adjusted hazard ratio for all these variables of 1.72 for the primary endpoint and 1.71 for the secondary endpoint. I'd like to briefly discuss what we found and how we interpreted these findings. So first of all, our first note was that peri-infarct ischemia might represent unstable myocardial substrate, since it is going along with a high number of adverse events in these patients. This may be the case due to electric instability in the myocardium affected by peri-infarct ischemia, with a propensity towards serious ventricular arrhythmias, since we also observed a much higher rate of CV deaths in these patients. And it also, peri-infarct ischemia might also negatively impact reverse remodeling after MI, since we also observed a higher rate of heart failure hospitalizations. It so far remains unclear whether peri-infarct ischemia represents a chronic irreversible condition, or if this condition might be mitigated by any approach, for example, by invasive revascularization. So further trials should evaluate whether peri-infarct ischemia, whether the prognosis of patients with peri-infarct ischemia might be improved by invasive revascularization. And with that, I'd like to thank the audience, and I'm happy to discuss any questions or any comments.
Yeah, thank you very much for the overview. Very well presented. For all, please post your questions in the chat, and I would like to kick off, although we will not have too much time. So you said segments. So now segments, especially given the fairly high spatial resolution of CMR, one might argue you may miss small amounts of ischemia if you take the entire segment. So how did you define whether there was any involvement of any segment considered positive, or did you require a certain amount of 10% or 20% of the segment to count as involved?
No, we took any involvement of the segment as positive for the segment. I totally agree with you that it would be, we would have had the possibility to go for a higher spatial resolution. However, I'm not sure if we can directly compare ischemia and LGE in the same segment, especially the transmurality extent.
Yeah. Okay. So then there's a question from Fahime Kanbari. How did you match segments between LG and perfusion images, given that perfusion only covers 3 slices, but LG covers the entire stack? Although also the exclusion criteria mentioned acute MI within 30 days, did you explicitly exclude MVO, so microvascular obstruction? And then also an explanation why she asked for the MVO, but maybe you answer the question.
We excluded all patients with a recent myocardial infarction. That's absolutely true. We did not explicitly exclude patients with MVO. However, I think this would affect the minority of patients because we had this 4-week time frame.
Yeah, I think the referral was because in figure 2, patient 3, indeed, there was, I also thought of that, there was the low signal intensity was basically within the infarct and therefore may represent a microvascular obstruction instead of ischemia. So yeah, here and the right.
That could be a clot. There could be a small clot there. You're referring to the right panel.
Yeah, no, I think where the arrow points to, so this could theoretically be microvascular obstruction in so because if it's within the infarct, I guess that's the point here. Then it is low signal, but not necessarily peri-infarct ischemia.
No, maybe I did not explain it quite well. The blue arrows here, they do not represent peri-infarct ischemia. They represent the infarct, of course.
No, I mean the red arrow in patient 3. I think that's what
this one here. Okay.
Yes. Because it seems to be subendocardial. There is necessarily no associated LGE. At least it's not easily detectable. So I think that doesn't change the overall results and the importance of the work. It's just let's say an interesting detail to discuss. Before we move on, just one short question, short answer. The direct comparison of infarct versus infarct plus peri-infarct ischemia, because you said ischemia or infarct was in your table, but just an infarct. So how much adds the peri-infarct ischemia to any infarct that might be there? So could you?
So in the multivariable analysis, we had adjusted for not only for the presence of infarct, but also for the extent of infarct, and it was still highly significant and a strong predictor. And maybe we can also take a brief look at the event curves. As you can see here, these groups are also groups with ischemia. So this is ischemia without infarct, and this is ischemia and infarct. And the patients with peri-infarct ischemia still had a worse prognosis compared to these 2 other groups.
So the bottom line is it really matters whether there is peri-infarct ischemia, and this may be a very important guide to further interventional strategies in patients after infarct, and especially if they have persisting symptoms. Thank you very, very much. We're a little bit already.
Can I make one clarification?
Of course. Yeah.
On a method? There's a question. So because it's a multi-center trial, we have to ask the other 12 centers to grade the presence of the infarct extent and the ischemic extent at a segmental level, because different sequences have different resolution at different sites. So at this point, we can only call peri-infarct ischemia at the segmental level, and that's how we match the perfusion and LGD.
Okay. No, thank you for the clarification. Okay, thank you very much. So Benedikt, if you could unshare your screen, and then Sonia, if you could share. We will have to go a little bit over time because I don't want to take too much time away from Sonia's presentation, which comes from Marco Goethe's group and was published in Scientific Reports, and it's called Clinical Implementation of a Fully Automated Quantitative Perfusion CMR Imaging Workflow with a Simplified Dual Bolus Contrast Administration Scheme. So Sonia, take it from here.
Thank you. Do you see my screen?
Yes.
Okay, perfect. So thank you very much for the invitation and the opportunity to present our manuscript during today's journal club. So as we know, recent technical advances allow quantification of myocardial blood flow by applying quantitative perfusion CMR. A critical step in the process of MBF quantification is the accurate assessment of arterial input function. And in qPCMR, we assume that there is a linear relation between the myocardial contrast enhancement and arterial contrast enhancement. Therefore, we need to be sure that there is also a linear relation between concentration of contrast and signal intensity in the blood pool. The problem is that if we inject a standard single bolus of contrast, we do have high concentration of contrast in a blood pool, which is prone to T1 and T2 star saturation effects. Therefore, the relation between signal intensity and contrast concentration is not linear anymore. That's why if we have such a situation, the arterial input function curve is truncated, and the overall result of MBF quantification is inaccurate. Currently, there are two solutions to this problem. The first one is application of a dual sequence image acquisition method, which uses a standard single bolus of contrast. However, it requires a specific pulse sequence, which acquires two different types of images within the same cardiac cycle. This approach is considered easy to use because we have only one single administration of contrast. However, the limitation is the need for this specific pulse sequence. The other solution is the dual bolus approach, which enables to use the standard regulatory approved commercially available sequences. However, here we need to prepare two boluses of contrast. In a standard approach, let's say, we need to prepare the pre-bolus with dilution of neat contrast. So it is time-consuming, not very practical and convenient in the daily clinical practice in our CMR lab. And my major milestone recently was establishing of a fully automated pixel-wise qPCMR framework, which enabled operator-independent and time-efficient post-processing of qPCMR images, and therefore allowed us to speed up the process of image post-processing. So in this study, we clinically implemented a ready-to-use qPCMR workflow combined of two elements. So first, a simplified dual bolus contrast administration scheme without the dilution of a pre-bolus. And the second element was fully automated QP post-processing. The study aimed to evaluate two things. So first, the image quality, and secondly, the results and diagnostic accuracy of this proposed workflow to identify obstructive coronary artery disease. So we analyzed 25 patients with suspected myocardial ischemia who underwent both adenosine stress perfusion CMR and invasive coronary angiography or CCTA. The patients were scanned on a 3 Tesla whole body MR scanner according to the simplified dual bolus contrast administration scheme, which you can see here. So basically, after we started infusion of adenosine, and after 3 minutes of infusion, we administered first pre-bolus of contrast, and it was not diluted. It was just a small volume of contrast, of neat contrast, injected at the speed 3 milliliters per second, flushed with 20 milliliters of saline. And then we acquired arterial input function, so pre-bolus images, and then we proceeded with main bolus with higher concentration to acquire stress perfusion images. And basically we did, after like at least 10 minutes, we did the same for rest perfusion. The assessment of image quality and diagnostic accuracy was performed by 2 independent CMR level 3 experts. So first, let me show you the Likert scale, which we used. So first we asked the experts to look only at the quantitative perfusion pixel-wise maps and decide if this patient has obstructive CAD or no obstructive CAD. Then the experts were shown conventional grayscale images, first pass perfusion images, and were asked to grade these images in terms of presence of artifacts, presence of noise, overall impression of image quality, and certainty in diagnosis. And then they were asked to make a final conclusion: is it a patient with obstructive CAD or no obstructive CAD? So let us take a look on the group that we analyzed. So we had 25 patients, 64% were male, mean age 60 years old, patients with the cardiovascular risk factors and comorbidities. 23 patients underwent coronary angiography, 2 patients underwent CCTA, which was used only to exclude obstructive CAD. And I would like to show you the typical examples of the images that we acquired. So this is an example of a patient without obstructive CAD. So what we can see are the images for the assessment of arterial input function, also the curves, which are of very good quality. No perfusion defects visible in the conventional grayscale images and in QP pixel maps. And the value of stress MBF, the mean global value was 3.1 milliliters per gram per minute. The next case, which I would like to show, is an example of a patient with obstructed right coronary artery. And here we can clearly see hypoperfusion in the RCA territory, both on visual assessment like grayscale conventional images and also QP pixel maps, with reduced stress MBF values in this region, with the mean value in RCA territory 1.3. We compared stress MBF values in ischemic myocardium, so supplied by a coronary territory which was obstructed, and the value of stress MBF was significantly lower. A value of stress of rest MBF was slightly higher in ischemic myocardium. And regarding the quality of the images, all of them were graded by two experts, at least moderate quality. And regarding the certainty in diagnosis, most of the cases were graded with good to excellent certainty in diagnosis. The per-vessel analysis revealed that the cutoff value, optimal cutoff value for regional stress MBF to predict significant coronary obstruction was 1.84 milliliters per gram per minute or less, with the corresponding area under the curve 0.79. Visual assessment of only color pixel QP maps by CMR experts yielded an accuracy of 80%, with sensitivity of 90% and specificity of 73%. And the combined assessment of both QP pixel maps and conventional grayscale perfusion images yielded even higher diagnostic accuracy of 84%, with sensitivity 70%, specificity 93%. A couple of words about the limitations of the study. So first and foremost, small sample size. And also, after we excluded coronary territories with LGE, the prevalence of coronary artery obstruction was relatively low. We also did not include healthy volunteers in our study. And also, last but not least, fully automated qPCMR software remains a research tool still. So to conclude, in this study, we successfully implemented a ready-to-use qPCMR workflow, which provides good image quality and holds promise for high diagnostic accuracy for detection of obstructive CAD. This workflow may be easily integrated into daily clinical practice and may serve as an alternative to current methods, increasing the accessibility of high-quality qPCMR imaging by a wide range of CMR laboratories. Thank you so much, and I'll be very happy to hear your comments and address your questions. Thank you.
Thank you very much for the very clear presentation. And I'm sorry that we're already a little bit over time, but I have a very simple question first. And first a comment. I think it's interesting and to me reassuring that you found an increased resting blood flow in patients with coronary artery disease, because this is not widely yet accepted, but I think there are some good data showing that at rest, in order to compensate for slightly reduced flow, there is the ischemic myocardium basically increased the rest flow. So this is, I think, both for me very reassuring seeing that. And the question I have is, would you, having performed this study, feel comfortable giving a less experience, because this is, if this is automated, one could argue, okay, you do not necessarily have to have a super expert then. You let someone even less experienced read or evaluate the scan using this technology. Would you feel comfortable, or do you think there are still, let's say, do you think it will still be dangerous because in some patients it may not work, or may totally overestimate or underestimate the findings? So what is your personal impression on that?
That's a very important question. I think there are studies which show that qPCMR helps to make a correct diagnosis in less experienced observers, CMR readers. However, I think that we still need, because it hasn't been widely implemented in daily clinical practice, I think we still need some experience with that. How to use it, how to read this pixel-wise maps. As you can see, even in our results, after correction or like viewing conventional grayscale images, the accuracy was higher. So, for example, I think an obstacle here using only qPCMR, I think that the presence of, for example, darkroom artifact may be a problem, because we can see reduced perfusions of endocardially, and then we might have some doubts if it's real myocardial ischemia, or if it's just an artifact. So I think still expert knowledge and experience with reading just normal first pass perfusion scans is necessary, and I think we need still some more experience with reading these maps in a daily practice in a real world cohort of patients.
Yeah. And the workflow itself, is it, because in the early days when we had to draw a lot of contours and try to find the curves and everything, so do you think the workflow is sufficiently simple now that an expert can do this in a short period of time consistently, or is it still labor?
Yes, well, I think if the quality of the image is good, so there are no triggering artifacts, motion, or any other artifacts, then the post-processing goes smoothly, I would say, and it's easy to use. However, if we do have some problems with image acquisition, especially, for example, if we acquire the basal slice too high, so we have part of the LVOT, for example, then then I personally experienced some problems with contouring and with post-processing of these cases. So yeah, I think the correct and good image quality is the key here.
Yeah. Okay. Thank you. And last very quick question from me. In the old days, there was a perfusion reserve index. So you report here the stress myocardial blood flow and the resting myocardial blood flow. So do you think the stress myocardial blood flow will be good enough, or do you think there is still a role for the perfusion reserve index, which kind of tries to normalize to the blood flow at rest?
Yeah, well, that's a very good question. Actually, there is still a debate ongoing in the community, in the literature, which parameter is the best one, if it's stress MBF as a cutoff value to use in a daily clinical practice or NPR. NPR has a drawback to, like, in this sense that we incorporate rest MBF, and if the quality of the image is not enough, or we have problems, or we do not, for example, acquire rest perfusion, which it might be the case in a subset of patients, still requires time to acquire these images, then NPR, like the applicability of NPR is limited, and also there are many factors which influence rest MBF as well. So then NPR as a surrogate, like we have the proportion of stress over rest MBF, might have some limitations. So it's still an ongoing debate, and I think we lack large-scale studies on that.
No, but I totally agree with your points. I think if we would get to a point that we have enough trust into the stress blood flow, that we do not need the rest study, then that's already helping a lot, because at the end of the day, we have to make sure that this technology is also efficient and cost efficient. The more we need for that scan, the less it will be integratable into clinical workflows. Thank you very much, Sonia, for the fantastic presentation and the excellent discussion. So with that, sorry for going over time. I want to thank everybody for joining. The next one will be in October. On October 2nd, it will be Nicole Seiberlich presenting. She will announce the papers within the next 2 weeks or so. And so then I wish everybody a wonderful day and rest of the week. And see you next time. Thank you. Bye-bye.